Hello everyone, it is 12:30, so we are going to go ahead and get started. Thank you all for joining us. I know some people will be logging on in just a few minutes, but we're going to go ahead and get started with some of the introduction stuff, and then Dr. Lollar will begin his presentation here shortly. There's no video component for this session, so all of that should be turned off. If for whatever reason you do get a video screen that pops up to try to access your camera on your phone or your computer, just exit out of that. All of our phones are muted until we conclude and we are ready for questions, and we'll go over what to do at the end whenever we unmute the phones, just so we don't get any background noise. If you're listening to this live, it qualifies for 0.5 hours of Category 1 AMA PRA credit. Then you can get that credit by filling out the survey that is in the calendar appointment that you received with the login instructions. Follow through that, and then all of that information gets dumped into our CME tracker system, so you can go online and see how many conferences you've watched live with Carilion or the recorded ones as well. In that, usually they run about 2 to 3 weeks behind. So if you don't see today's thing on there today, it's because usually they run a few weeks behind. These sessions now also qualify for Category 1 AMA PRA credit as a recording through our Enduring Materials program. If you're listening to this as a recording, all you want to do is fill out the survey, the CME survey that's in the notes section of the video. So kind of scroll down a little bit. There should be a little notes icon. You click it, and then the survey is in it. And it does the same thing. All of our information gets dumped into the CME system. So for questions, like I said, the phones are muted, but you can use the chat button that's at the top right of the screen. If you have a question you'd like to ask during the presentation, chat with Alex. You should see my name on the participants list that comes up when you hit the chat button. Find me, send it to me, and I'll be monitoring on a side computer, and I can stop Dr. Lollar and ask him the question if it's something that's time sensitive. This is my contact information. I'm Alex Brindell. I'm the Director of Outreach and Special Projects. Here's my email here. If you ever have an idea for a webinar or if you need some assistance interfacing with Carilion Children's, you can always contact me. This is my office number right here. Always happy to be kind of the gateway for people to access Carilion Children's as well as our outreach network. This is just a quick self-promotion, shameless plug of our outreach work we're doing. So we do this monthly Lunch and Learn webcast where we do a really short, condensed session, about 20-25 minutes of actual content. We also have Pediatric Grand Rounds every Thursday morning at 7:30 that we webcast and you can find all of our recordings on the Carilion Children's Outreach playlist, which is on the Carilion Clinic YouTube channel. If you just go to YouTube and you hit the search box and you type in Carilion Children's Outreach playlist, we're right there. We have about 95 videos on right now. And like I said, all of our videos that we were posting starting in January 2017 now qualify for Category 1 CME credit. Also, just a reminder, start marking your calendars. December 1st is our annual pediatric conference this year at the Hotel Roanoke. We're going to be focusing on caring for children with special needs. Today's presenter is Dr. Daniel Lollar. Dr. Lollar did his residency in Fresno, California, and his fellowship in Denver, Colorado. He has been here at Carilion for about a year and a half, and he is a trauma surgeon with us. He's also the assistant professor of surgery at the Virginia Tech Carilion School of Medicine. And Dr. Lollar is going to be talking about the Stop the Bleeding campaign at Carilion Clinic. So with that, I'm going to go ahead and turn it over to him. Thank you all very much for joining us.
Hello, and thanks again for taking time from your lunch to join us and learn a little bit about this campaign that we're bringing to the Roanoke Valley. It's essentially, think of it as CPR for bleeding, and we're going to go through a little bit about essentially the basics of it and the justification for it. But I do just want to point out there ways of signing up for the program on Cornerstone that we'll talk about. But if there's any questions, if anything comes up, feel free to take down my email here, di.lollar@Carilion, and I can answer any questions that come up. I have no disclosures. From an objective standpoint, as I said, we will review the need and the justification for the Stop the Bleed campaign, where it came from, why it was felt that there was a need for bleeding control education, and why now, essentially. And then we'll go through a little bit about the actual objectives and the curriculum of the course, who should take it, and the answer to that is everybody, and essentially some of the logistics behind it. So after the Sandy Hook shooting in April 2013, again, there was felt to be a need at the national level for an organized response to these mass casualty events. In the government's infinite wisdom, they formed the Joint Committee to create a national policy to enhance survivability from international mass casualty and active shooter events, which fortunately became known as the Hartford Consensus, as the above would not really be particularly useful. This is a widespread collaboration between the American College of Surgeons, particularly the Committee on Trauma, Homeland Security, FBI, U.S. military, emergency medical response organizations, and again, it was felt that with the number of active shooter events and also the Boston bombing, that there was a significant need for bystander education. There have been a couple of different iterations of the Hartford Consensus. The first one essentially developed the mnemonic threat, which is a part of the class. We talk about threat suppression, hemorrhage control, rapid extrication, and assessment by essentially EMS and medical providers before transport to definitive care. And I think this is important. The Hartford Consensus 3 was really where they developed this, the bleeding control course. I think it's kind of important to understand that previous to the work by the Hartford Consensus, the approach that law enforcement and EMS had to an active shooter event was essentially containment. So if there was a threat that had not been known to be neutralized, law enforcement would essentially create a barrier and try and, again, work on that threat suppression, while EMS essentially staged outside of the scene. And what they found was that this period of time was a time when a lot of people, or not a lot, but a number of people bled to death from wounds that might have been salvageable. And so Hartford Consensus established this idea of essentially trying to create immediate responders. And these are people who are bystanders but have some basic education and are present initially on the scene of an incident. Therefore, there's not a separate sort of staging area between people who can respond to an injury and don't have to wait for the threat to be completely neutralized before the scene can be cleared to provide medical care. Again, then you have the established roles of professional first responders and trauma professionals in this tiered system. But this idea of educating bystanders to become immediate responders is where the bleeding control course comes in, because there really wasn't anything that was, again, essentially CPR for bleeding that could be taught in a fairly short period of time to people who had otherwise no medical education. So sort of an overview of the bleeding control course. Again, it's intended for lay people, people without any previous medical education, and it's analogous to CPR for bleeding. It's again, essentially BLS, and anybody who knows how to do CPR, who knows 30 and 2, how to use an AED, this is essentially analogous to that education. In BLS, they use AEDs. That's their equipment of choice. In bleeding control, we use tourniquets and combat gauze. Essentially, the class is it's a maximum of 2 hours, I will say. We've done some classes that have taken as little as an hour and 15 minutes, an hour and a half, but we allot 2 hours. The class size is technically 20 people. It's really per instructor. Again, we've done bigger classes with more instructors. You can do classes of 40, but you just have to make sure that the student-instructor ratio is maintained. There is a didactic portion, and we're going to go through some of the sort of example slides that are in the curriculum. This is in no way substitute for actually taking the course itself, but we'll give you some idea of the curriculum that we go through. I think, again, there's also practical portions where we go through education on tourniquets and combat gauze. We have actually a kind of a cool mannequin which has fake blood and fake gauze, but when you put the two together, it actually creates clots that are pretty similar to real life. It's a proprietary product that we utilize, and then we also, again, have training tourniquets that we practice placing on ourselves and on other participants. If you have initials after your name, so MDs, RNs, ACPs, once you take the course, you can actually instruct the course. So it's a positive feedback loop. And so far we've trained over 50 people who can now be instructors. So as I said, we've had sort of a positive feedback mechanism with that. And that is to say also that if you are somebody who has some experience with tourniquets, with trauma, and you don't feel like this is particularly new, by taking the course and investing that hour and a half, you can then instruct that course and pass on that education. You don't have to take a second instructor course. All right, so some of the slides from the actual bleeding control course. Again, this is part of the Stop the Bleed campaign from the Hartford Consensus. The focus of the program is creating immediate responders to bleeding patients. Part of that is recognizing what is life-threatening bleeding and what is not. What are appropriate ways to stop bleeding? And again, it's the idea that people want to help. People want to save lives, and they just need the training and the resources to do that. We sort of talk about the primary principles of immediate response as an overview, similar to the airplane videos where they say apply your mask to yourself before helping others. Ensuring your own safety is of paramount importance. While these are fairly fluid situations, potentially, you can be safe and provide help, assuming, again, that there's no immediate threat. The ABCs of bleeding, the first step is to alert people. Presumably, folks know what's going on, but that's not an assumption that can be made. So reaching out, again, similar to CPR, calling 911, whether it's making a phone call, texting, the internet, get help, get people aware of what's going on. The second step is assessing the bleeding, identifying where it's coming from, not just the general location, but actually exposing the wound enough to evaluate it, identify, is this a bleed that's life-threatening? And then C is compression, applying pressure to stop the bleeding. And again, there's a few different techniques that we go over during the class, including using just a clean cloth and putting pressure directly on the wound, using a tourniquet, or using a wound packing technique, either with a gauze, preferably a combat gauze, or a clean cloth, and then similarly applying pressure. I think it's important, one of the things that the class goes over is the difference among the different types of bleeding. So there are really sort of three classifications of bleeding. The one is compressible bleeding in extremities. Arm and leg wounds particularly are the most frequent cause of preventable death by injury. And this is really where we're looking at trying to prevent injuries. In addition to, or as an adjunct to this campaign, there's a nationwide white paper that came out recently called Zero Preventative Deaths in Trauma. And the idea is that there are over 30,000 people a year who die from preventable trauma. And the biggest classification of those deaths are in patients that have extremity bleeding that do not get hemorrhage control. These are wounds that are most amenable to tourniquet use. They can also be controlled using direct pressure. And again, there's a nice sort of picture there on the side that gives you some idea of the area of the bodies that we're looking at. It should also be noted that there are some fairly graphic pictures in this presentation, so it's not for the squeamish. The second group are what's called torso or junctional wounds. These are wounds that are in the neck, shoulder, or groin. They're wounds that really aren't amenable to control by a tourniquet. Obviously, you can't put one on the neck. And trying to place wounds over the shoulder, or tourniquets rather, over the shoulder or in the groin is fraught with danger, particularly of not being able to control the wound. For these types of wounds, this is where the wound packing is important. And again, either direct pressure or by actually packing the wound. Typically, these are wounds that need to be exposed and really get the feel for the size of the wound before treating folks. We do go through some algorithms. This is just one sort of screenshot. Again, going through that process of ensuring your safety, identifying the bleeding, identifying your resources. Is there a trauma first aid kit available? Is this a wound that is compressible? And if so, apply a tourniquet to the arm or the leg. And again, there are other slides where they go through, well, no, there's not a first aid kit available. Okay, identify any kind of clean cloth or anything like that. Is the wound in a junctional area? Is it in, sorry, to complete the thought, the torso is the third area where bleeding can occur that's life-threatening. This is not an area that can be managed in the field, and it really requires definitive care in a hospital setting. But identification of those patients is important, and so just identifying where the wound is and and knowing what kind of treatment this patient will need in those three big groups of tourniquet, wound packing, or extrication to a definitive care. After we go through the practical portions, again, after we go through the didactic portions, there's then a practical portion, and really these are two areas, two stations rather. One is applying tourniquet to yourself, and the other on an arm and a leg. Well, we'll talk about that in a second. And then the second one is how to pack a wound. Again, there's part of the didactic class is going through the steps of putting on a tourniquet. We use there are different kinds of tourniquets, either the cat tourniquet or there's also a soft T type tourniquet. They both are pretty similar. Essentially, they're a loop, Velcro loop that you apply snugly to your arm, Velcro it down, and then there's a windlass rod here that you tighten down and make sure that the essentially until the bleeding is controlled. So we go through those steps and again practice that both on ourselves and on a partner, applying them both to the arms and the legs. It is somewhat different applying to the leg. It's also, we go over pitfalls to tourniquet application. Most of the pitfalls involve either not applying the tourniquet early enough, not applying it tight enough, or also only applying one tourniquet. Sometimes in the legs you need to apply two on top of each other, or side by side rather, to control the bleeding. And then we go through wound packing as well, talking about the differences between packing into the wound versus on top of the wound. And as I said, there's a mannequin which we practice on with a proprietary product that really does a fairly decent job of creating the situation of an actual deep wound bleeding. So that's about the long and short of the class itself. Currently, we are rolling this out, as I said, in the Roanoke Valley, and we've applied for a couple of grants to try and bring, right now, the class to essentially all the teachers in Roanoke City and County schools. Sorry, just to kind of bring this in with the pediatric world. For the most part, these tourniquets will work on children. If children are too small for the tourniquet to work, usually direct pressure is adequate to stop the bleeding. But we want to bring this, again, into all the schools. Part of the funds are used for training, but a big part of it is, again, the idea that in addition to having the education, we need the resources. And one of the, I guess, visions is to have a bleeding control station for every AED that's available. So a bleeding control station is essentially 10 packs, individually packed tourniquets and combat gauze, gloves, scissors, and then you can open the station and have, again, 10 different kits which are rapidly deployable in the case of something, some uncontrolled bleeding. We would also like to expand this training into the Carilion system and training particularly Carilion employees who are not in the hospital and do not have a lot of trauma experience, to be able to have some education and bleeding control station in some of the outlying areas, I think would be really helpful. Again, as we move out, we really want to try and train all the primary care facilities and have a bleeding control center in each facility. Other areas that are potentially high risk for having events like this are shopping malls, museums, anywhere there's a big group of people, theaters, transportation centers like the airport, and any place where, which is particularly common in this area where there's limited or delayed access from extrication. Other, potential targets are outlying school districts, and the goal again is to have a bleeding control center with every AED. So for now, these are the education pamphlets. The Stop the Bleed course is being taught here at CRMH. It's every third Friday of the month in the morning from 10 to 12. You can sign up for the classes on Cornerstone. Again, if you have any questions about being able to sign up for the campaign, there's an email down there for S.E. Helms who can get you hooked up with getting registered appropriately. Any questions at this point?
Okay, I'm going to slide over here and pop us back on speaker. I actually have several questions. I'm going to go ahead and unmute the phones. So if you are on the line and you do not have a question, just please mute your phone so we don't hear anything going on in your background.
The conference is now in talk mode.
Okay, so I have the phones unmuted. Before I jump into my list here, does anyone on the line have any specific questions? Okay, so I'm going to try to, I'm huddled around the speaker here. You've used a term in here a couple times. I just wanted to make sure I understand. Combat gauze, are they different than regular gauze? Do they have like a quick clotting material? And can you briefly talk about that?
Yes, actually, that's a great question. Sorry. They are there's a couple of different kinds. Each have their own proprietary product, but they are special gauze. They typically have enzymes in them which enhance the clotting reaction and therefore increase the clotting and decrease the time that you theoretically have to apply pressure. We teach in the class that really you need to continue holding pressure until help arrives, but the whole purpose of the specific combat gauze is, and that's actually, combat gauze is a proprietary name. There's some, again, there's some other ones as well that we talk about in the class, but they are special types of gauze which have an additional product in them which helps clotting. One thing I will say, and that kind of leads to the second question of do these expire? And technically the shelf life of these special gauzes is usually in the realm of about 5 years. However, if they do expire, you can still use them as regular gauze. But as I said, that enzymatic reaction will not be as robust.
Great. Thank you very much. All right. The other questions I have are more for people who are not within the Carilion system. So I know one of the goals, and I'll throw this back up here, our future plans. If there's someone at either one of these large centers, an airport, a sports venue, something like that, or someone at an outlying hospital, I mean, we have a large region here that Carilion serves, should they try to get in contact with SE Helms? Should they try to get in contact with you if they're interested in starting a program of their own, or maybe sending a few people to this class and then taking that back? I mean, how exactly would you suggest someone handle bringing this concept, this idea, into a non-Carilion setting?
I would say the best way, so right now, again, the big issue, as it usually is money. We're happy to bring these classes to anyone in the community, but there is a fairly small price for that, just essentially the training supplies, something on the order of $125, $150. The best way to do that is probably right now to email me, again, D.I. Lollar at Carilion, and I can forward that on to the to our trauma outreach folks who can help set that up. Again, the goal is to try and get this out without there having to be a cost associated with it, but we're just not there yet.
Okay, thank you. I think those cover the majority of the questions that I've either seen come through or that I've had while I was listening. Does anyone else on the line have any other questions? We've got about 2 minutes left. No? Okay. I'll leave the phone open for the next minute while we are wrapping up here in case someone has a question. You want to, I think we've kind of pretty much covered everything on your summary slide here. Is there anything else you want to use as key takeaway? Okay. Here's your, again.
Yeah, I'm sorry. Okay. Yeah. Sorry. So that SE Helms, yes, that's the that's also, you can also email that person. That is our trauma outreach coordinator. Sorry, it's a different last name, but that is a good email for access.
Great. Okay. So if you are on the line, remember this does qualify for Category 1 AMA PRA credit. If you're listening live, don't forget to fill out the survey that is in your calendar appointment. That is how you will get your CME credit. If you are listening to this as a recording on our YouTube playlist, remember you can go to the Notes section and expand that, and you can see the survey there. All of these get sent to our CME tracker system, and if you want to what the CME website is for Carilion, it's a long one. It's carilionclinic.org/continuing-medical-education, and that's where our CME tracker system kind of lives, and you can see the contact information there. As always, if you'd like to join our Children's Outreach Network for these webcast listings, for any of our communications, things like that, you can always email me here at outreach@carilionclinic.org, and I'd be happy to facilitate anything I can. And with that, we are going to go ahead and disconnect the phone lines now since we don't have any further questions. Thank you all very much for joining us, and enjoy the rest of the day.